prevent adverse outcomes. So now, I take this opportunity to introduce our esteemed speakers for the day, Dr. Sahana and Dr. Jatish. Dr. Sahana is the Joint Managing Director for Apollo Hospitals, Bangalore.
Preet, are you there with us? Over to you, Dr. Sahana. You can start your presentation, I guess.
Okay, Soma, thank you. So I will be sharing my screen now. Just let me know if you can see my screen.
Put it in slideshows, Dr. Sahana.
Excuse me, madam. Excuse me. Voice is not audible.
Yeah. Is this okay?
Mute করলে সবারটা unmute হয়ে যাবে.
Okay, so Soma, I'll start.
Yes, ma'am. Please go.
Right. Okay. All right. So good afternoon, everybody, and welcome to this wonderful session. I'm going first, and Dr. Yatish is going to go after me. So the topic that I'm going to be talking about is the key elements of a successful hospital safety program. So so we decided that the key to run any successful hospital safety program, we have to have a combination of a successful patient safety program, an environment safety program, and a staff safety program. So I'm going to start off by talking about the patient safety. So I know over the years there's many definitions of what patient safety means to every one of us, to everyone who's working in healthcare, or but so this sort of resonated with me. So the Canadian Patient Safety Dictionary in 2003 came up with this definition that said patient safety is actually reduction and mitigation of unsafe acts within the healthcare system, as well as optimizing patient outcomes through best practices. And I guess one way or the other, all of us have sort of been following the same structure. So essentially, we all know that a significant number of patients are harmed in a healthcare organization. We've been talking forever how hospitals are probably the most unsafe place there is for a patient. So there is permanent injuries, there is increased length of stay, there is even death and medication errors, obviously, patient falls. And it's also said that there are more deaths in a year in an healthcare, when you combine road accidents, breast cancer, and AIDS all put together, the deaths in the hospitals are more. So exactly how safe is this, and what can we do to mitigate this and make this safe for everybody? So I mean, just at a top of the head, these are some of the things that why I think the statistics is a reflection of why patient safety is important and why it is a problem. This is just a broad outlook, and the latest data is from the University Hospital of Riyadh, which was in 2014. So essentially, we see that the adverse event rate in any of the hospitals, be it a developed country or or a developing, is quite high. And I think this is the story everywhere. This is a story everywhere essentially because I think it is not one patient and one employee or one staff that takes care of a patient. A patient comes into a hospital right from the time a patient enters a healthcare organization to the time that they exit. There are hundreds of touch points where errors can happen. It involves many people that are put together, or that sort of come together towards taking care of one patient. and add to this some of the environmental issues, add to this some of the safety, the system issues, you can understand why this is a very important aspect in patient safety. So these are some of the key elements, and I will be talking about a part of each one of them and how this is important to address patient safety issues. So when we talk about safety, we essentially are talking about avoiding injuries to patients from any care that is intended to them. So it has to be a safe practice for that patient. When we say effective, we basically are saying we do the right thing for the right person at the right time. And this has to be done every single time. Every single time we do the right thing for the right person at the right time. And these are based on scientific knowledge, these are evidence-based, and it has to provide benefit to the person that it is intended to. And it has to be timely. Any care, any action has to be timely. You have to reduce the waits and sometimes delays inadvertently or otherwise to both those who are receiving the care and those who are giving the care. And this, and we've all been talking about how inclusive the treatment should be, how family and the patient themselves should be included in their own care, and how they should have a say in their care. So essentially the care that we formulate for a patient needs to be family and patient centric. It has to be responsive to that individual and their preferences, their needs and values. And this should actually guide all the clinical decisions that one takes in a hospital. It has to be efficient. Any care that you're giving, any intervention, anything has to be efficient. You should avoid waste, especially waste of time, energy, supplies and equipment. And it has to be equal to everybody across the ecosystem. There cannot be a difference in the care based on anything. So these are the key, I think the 6 key dimensions of healthcare. We all know that errors happen. Like I told you, there are multiple touch points from the time the patient walks into an organization to the time the patient exits. And it is not always possible, I think, that that everybody delivers optimally at all times, because this involves humans. This involves people probably at their very stressed or at the very low. Probably they haven't had a good night's sleep, or they've had a family issue, or there's some personal issue going on. So when you have all these on the table, it just makes healthcare that much more difficult, that much more challenging, because at every point of time the expectation is everybody that is involved in patient care is involved 100%. Now, who has a responsibility of ensuring that? I think it's a shared responsibility, but we all know errors happen. Errors could be active or human errors where it is committed by a frontline staff, and that tends to have a direct patient consequence. For example, we've given a wrong medication, or we've treated a wrong patient, or we've done a wrong surgery. It could be a latent or system errors where generally there are external forces that are acting upon this. You have, this involves management, this involves protocols, this involves culture, this involves training, transfer of knowledge. Like, for example, you could have an inadequate equipment, you could have staff that are either not trained properly, or you could have shortage of staff. And we all know the kind of errors that can lead to. So I broadly classified this into two main groups. So essentially, what is a patient safety culture then? Patient safety culture then, to take the example of a medication error again, we either have a blame culture going on, or we have a just culture going on. We have a blame culture where there is an error that has happened and we penalize somebody, or we identify somebody to take the blame for that and make that person the fall guy. It could be the individual student, it could be the pharmacist, it could be the nurse, it could be the doctor. Now, in case of a medication error, we know there is prescription, there is transcription, there's administration, so any of that could go wrong, but we will then try and identify a person and try to hold that person accountable. Or you could have a just culture where we look at the bigger picture. We look at the external things. We look at the broader things. We're looking at communication. We're looking at protocols. We're looking at processes that may be wrong. Obviously, we need to investigate. Obviously, we need to address the recklessness of a worker, or if there was a negligence, or if it was willfully done or inadvertently done. We need to address all that. But we're also looking at a bigger picture. So I think universally now, we've all come to understand that there's only so much of blame culture. It's not going to hold you in the long run. We have to look at the just culture. We need to try to fix what can be fixed. And for this, I think there's a lot of things that all of us can do. And one of the most important thing that I think an organization can do as part of practicing just culture is raising incidents. An incident reporting system is a very, very robust way of identifying what could have happened and what we can do to mitigate that in future. We all know incidents happen. There is no system that is foolproof, so incidents happen. Sometimes that results in damage that has been done to a patient, to an equipment, to the facility. It could result in loss of life, loss of a limb. It could be a deviation from anything that is not normally accepted. I've put down some examples there, and these are some of the examples that could happen in a healthcare organization. And similar such incidents can happen in any organization, be it healthcare or otherwise. But what I think is important is where we promote people to come forward to actually report that and not try to hide that, because I think then the damage that gets done from not reporting is much higher. And again, the result of reporting a clinical incident or anything that puts the processes at risk, the only thing that comes out of that is there is a group of people who are actually addressing that and trying to learn from that and hoping that that mistake does not happen again. And if it happens again, too bad, probably we didn't fix the system properly. So everything essentially results in fixing the system to make it the safe place for the staff to be in, for the patient to be in. So this is I think a very, very nice practice towards pushing an organization to practice just culture. So then we also have to talk about environment safety, because this is a very, very important part of any healthcare organization. This is critical for life support, and this also sort of is in the mix of patient and organization safety. So some of the environmental factors that could play a very important role is waste management, noise, infection control, radiation safety, general building safety, water quality, and HVAC. So I mean, waste management, so generally there's a lot of waste that gets generated. We all know gets generated, and in any hospital, 80% of it stems out of general waste, and 20% of it is hazardous waste. But waste is waste, and our responsibility as a healthcare organization does not end when we have taken this waste, segregated this waste, and handed this out to whoever takes care of it. Obviously, as an organization, we will be very aware, and we are constantly monitoring the waste that gets generated. We are aware of the kind of waste that gets generated, the kind of segregation that happens, the kind of collection that happens, the kinds of bags that goes into, and all this, of course, is within the remit of the local laws and regulation. We also have to make sure that the area where this waste is stored before it's picked up, what kind of an area that is, if that meets with the local laws and regulations, the temperature that we monitor in these areas, and the transport requirement. Obviously, not a lot of this can be taken care of by the organization. This needs to go out to another organization or an outsourced facility, and they take care of it. So until that organization or the outside agency is actually taking care of it and is completely and properly and safely disposed of all the waste that gets generated in the organization, I think that is the responsibility of that healthcare organization to ensure that that happens. Then we have noise. All of us have worked in a hospital. All of us have worked, at least visited a hospital, if not worked in a hospital, or worked in different different organizations, not necessarily healthcare. We all know what difference and how much of a difference it is when there is a lot of noise around us. Sometimes it's white noise, sometimes it is noise that could create in a lot of errors. In a hospital, for example, you have alarms, paging systems, you have telephones that are constantly working, the computers, the printers, you have the televisions, you have the delivery cart, the staff that is talking, housekeeping activities, air conditioning, a lot of doors opening and closing. According to WHO, the recommended level of noise is 35 decibels. And we know for sure that it is way higher than that. And the other important aspect of noise, as it is is the stress that it causes on the system, on the staff, and sometimes even on patients and their recovery. So this is a very important aspect. And this, I think, is one of the reasons that a lot of hospitals, a lot of organizations these days are practicing what is called a silent areas, a silent hours in a hospital, where you have a couple of hours, probably in the afternoon when there's not a lot of activity happening, or 1 hour in the morning or in the noon when everybody is going to be talking softly, or they try not to talk, they dim the lights. There's a lot of all this to ensure that, errors don't happen. I mean, for example, if you go to any of the say a nurse station in the morning, say 10 o'clock or 9:30, 10, when there are consultants on rounds, when the patients are getting admitted, when patients are being shifted for either to the theater or for investigations, we know the kind of noise that there is, and that results in errors happening. It results in errors happening in that we don't either, we're not properly heard, or we don't hear what the other person is talking. Anything that causes extreme level of noise in a hospital is detrimental to the staff and to patients. Infection control, obviously there's nothing that can be said, or no matter how much we talk about this, it does not cover the topic. Infection control and the protocols are extremely important in any organization, be it a small setup, be it a clinic, be it a polyclinic, be it a hospital, a small hospital, or a big healthcare organization. Infection control plays a very, very important role. And the main components of it obviously is education and training, surveillance of infections, your policies that guide it, your procedures and guidelines, your audits that you do, what are the processes that you've put in place as a result of that, monitoring of hospital hygiene. Obviously, we have the WHO that's given us broad guidelines of standard precautions and additional precautions, and these are some of the examples of it. Time and again, we've witnessed what an hospital associated infection can do. All of us have lived through a pandemic. All of us understand the importance of hand wash. All of us understand the importance of hand hygiene. We've been through, social distancing. We've understood quite a lot of it. But this again, like I said, enough. You cannot really talk too much about this. You cannot talk enough about this and cover this topic. But I think it is a responsibility of everybody within the organization. This is not a management thing. This is not the doctor's thing. This is not the nurse's thing. This is everybody's. And this also comes, I think, a safe and a good infection control practice can only happen when you have empowered every staff, when you've empowered a patient to ask the questions. And that culture has shifted. I think that culture has come about now, when a patient can question a healthcare worker and say, have you washed your hands? Have you done what you need to do before you touch me or you examine me or whatever? And I think that's a culture that we should promote as part of patient safety culture. We have radiation safety, and science and technology is developing every day. And the last 2 or 3 decades has seen amazing things happen in the realm of diagnostics, in the realm of therapeutic. And radiation is a very, very important part of both diagnostic as well as therapeutic factors. But the challenge, I think, to a healthcare organization is how to minimize the radiation exposure, because you have staff there, you have visitors there, your patient family there, and then of course you have the patients themselves. So successful radiation safety program, we really should try and balance that with engineering safety and personnel training. We have to take into consideration the technical part of it, the scientific part of it, the economic part of it, and the ethical aspects of radiation use. And the radiation, I know every organization has to have a radiation safety program. We have radiation safety officers. We have patient education materials. We have patient education brochures that we give. There's a lot of education that happens in counseling, but broadly, I think the crucial factors is to spend as little time as possible in the vicinity of a radiation source, to double the distance between the person and the source, and to shield the person so that there is less radiation exposure. Then, of course, we have the general building safety, and now hospital buildings, and all this comes under, there's a lot of importance that's given to it, because we need to make sure that the building is safe, the organization of the structure itself is safe for the employees and for visitors. So accidents and injuries can happen due to falls, can happen due to collision, and these can be minimized through establishing a traffic flow pattern. And most of this responsibility lies with the organization to ensure that there is an established traffic flow, and this does not in any way endanger the people that's working in there. We have to ensure a clean, dry, unobstructed and slip resistant surfaces. We have to maintain railings and stair surfaces in good condition. We have to supervise patients to minimize unnecessary travel within the organization, fire and smoke alarm, gas cylinders and medical gases. Now, obviously, every hospital, every healthcare will have policies and protocols to ensure that all these are in place and damage can be minimized. Water quality, again, water is a very, very important utility that we use in a hospital, and the 6 major areas of consumption besides the smaller ones is sanitation, heating, ventilation and air conditioning, clinical and medical procedures, laundry, food services and miscellaneous. Now, it's a country that that does not have enough of this source. So obviously we have to half of the times rely on outside source as a medium to provide us the water. But that also makes sure that mandates that we make sure that the spread of infection does not happen from outside sources in the hospital. So we have to make sure that we run chemical analysis of the water. We have to have a local public health agency. The hospital staff needs to run this, and there needs to be we need to be guided by the universally accepted guidelines and what is the level of elements that we can find in this in water, be it chemicals, be it biological pollutants, several of which we know can be hazardous. So this needs to be monitored very, very closely. And the last one, of course, in environmental safety is HVAC. So the purpose of this is to maintain an environmental condition, including proper airflow in the hospital, heating and cooling to some or all areas of the hospital. Now, obviously, this is designed to meet specific values of temperature, relative humidity, air exchanges, and the frequency in multiple areas of the hospital. You would have a ward, you would have OT, you would have cath labs, you would have ICUs. So, so one has to take into account all these areas to make sure that there is, if any of these require special ventilations through filtrations like HEPA and all that, we are taking care of all that. In general, we have to ensure that there's a clean atmosphere that reduces the risk of airborne infections and the dangers of gases that explode within the organization. So these are some of the general factors of environmental safety. Obviously, one cannot cover everything, but these, I think, fall under the important topics. And I thought the last thing that we should really be talking about is the staff safety. And these are some of the things that I thought was really important, because as an organization, any organization, and I'm not really only talking about healthcare, any organization, I think the first step that we can as management do to ensure a staff is safe is choose the right candidate. I think we have to understand that the person who comes in, if the person that joins an organization has the same vision, has the same passion, and agrees to the organizational culture and ethos, then I think that employee is safe right from day one. Safe for the employee himself or herself, and safe for the organization, and in a healthcare setting, definitely safe for the patient. So it's very important that I really don't think we spend enough time, or human resources spends enough time, or as managers we spend enough time to choose the right person for the right job. And I think that's very, very important. Obviously, pre-employment health check is to ensure that the staff that is coming in is safe. So we have something to go by, and if there is something that can be fixed or addressed at the time the staff comes into the organization, we fix it. Induction, I think, is again something that I don't think as an organization we give enough importance to induction. Induction is when a patient, or induction, my apologies, is the time when an employee who's coming into an organization understands and identifies with what we are looking for. I think that is where we set our expectations on the table, and we get some understanding from the person from across the table. This is where we talk responsibilities of the organization, culture, we talk about organizational ethos, we talk about what we expect and what we deliver, what we will deliver, and what we expect them to deliver. And I think this is a very, very important point of ensuring that the organization is safe. And when you break ice, when you induct a proper person and induct them properly into an organization, I think you are ensuring a safe culture. And obviously, you're introducing the person to an organizational culture, then the person then needs to walk the same walk. He needs to talk the same talk. Then you understand that the passion is there, and the passion has been passed on from the organization to this staff who's coming to the into the organization, and then that the person is going to own up. The minute you have a staff that you have recruited, you inducted into the organization, who says, what, this is my home now, and I own this home, so this is my problem and I will address this. I think when you have any staff that says that, I think that's the battle won already, because you've made sure that that organization is a safe organization. And I think we need to do this for every staff, every employee who walks into the organization. And we've already spoken about just culture. This should be the talk of everybody. This should be what is spoken about in the corridors, in the staff cafeterias, in any place. People should be talking about what a just culture this organization practices. And it's not just enough to practice that. I think people need to be motivated continuously. People need to be told that they're doing a good job. So you need to recognize them. Even small things is good. It's really good when somebody stopped and said that, what, I appreciate what you did for that patient, or I appreciate what you did. I think you showed admirable skill and leadership quality. I think that goes a long way in ensuring that we bind that person to the organization. So recognition and rewards are very, very important. And continuous training. I did allude to this before. I said a patient that comes into the organization has at least 100 people that patient meets before, for say an average loss of maybe 3 or 4 days. Maybe 100 is maybe 50, maybe 60. But you see, with every one person that the patient is meeting, the chances of error, the chances of it being a unsafe organization increases. So I think the only way we can correct this is by continuously training, continuous engagement. All of us have been through pandemic. All of us have been through attrition. All of us are going through certain amazing challenges in our everyday life. And I think the only way of surmounting that is to ensure that we continuously train and engage our staff. And finally, I think you need to really empower them. Unless we've empowered each and every staff, each and every person who walks into the facility, including the patients, I think we are not going to be successful in driving a safe and a safe patient culture or a safe environment culture. We will not. I think everybody should speak up. Everybody should be told to speak up. While we give them opportunity to talk of the good, I think they should also feel free to point out what is wrong. And I think that kind of empowerment comes when as an organization, you want to do what is right for everybody who is working. And I think that is a very, very important part of a safe patient culture. And obviously, you have staff, you have employees in the organization. You need to take care of them. They need to be safe. Their families need to be safe, not only for us in the organization, as a country as a whole. So we have to ensure that we take care of them and their families. So we do annual checks, we do vaccination, we give them continuous training, we take care of all their other smaller needs. And I think this sort of what it does is, I think it builds a relationship. And I think once you have a relationship that is built, then I think everybody speaks about a just culture and a safe culture for everybody, including themselves. So this, I thought, was in a nutshell what we need to do to ensure that the staff is safe. So in conclusion, I think patient safety is the avoidance, prevention, and amelioration of harm from healthcare. Just culture is definitely the way forward. Adverse events often occur because of system breakdowns. Therefore, standardizing and simplifying clinical processes is a very powerful tool in improving patient safety. Ultimately, of course, the idea is to minimize any preventable harm, infections, or injuries within a healthcare organization for both the internal as well as external customers. Thank you so much. Thank you.
Thank you, Dr. Sahana, for such a thoughtful presentation on developing a robust patient safety plan. And the key takeaways that we could gather from your discussion were that we need to understand the 6 dimensions of healthcare quality while we are preparing the patient safety plan for our organization. We need to understand how to avoid systemic errors. What is the importance of reporting clinical incidents? And understanding the 7 factors that are important to create a safe hospital environment. Now, my request to the audiences before we move to the next session is that in case you have any questions and doubts and you wish to interact with Dr. Sahana, please post your questions on the chat box. After the second session, we will take up the audience questions. And now we are moving ahead with our discussion, and over to Dr. Jatish for his topic, developing patient safety system in hospitals using the WHO tool. Dr. Jatish is the Vice President, Apollo Hospitals for the Jayanagar Hospital. He has an immense experience of 20 years. He started his career as an emergency physician, and thereafter he completed the hospital management program in IIMs. He was also the medical superintendent of Apollo Hospitals, Bangalore, before he started his current role. He has successfully led the accreditations for JCI and NABH hospitals for all his units, and he effectively executed the clinical governance program in the Karnataka region hospitals. Besides being an effective business head responsible for the unit leadership, he has also been awarded the Emerging Young Leader Award by GAPIO, the Global Association of Physicians of Indian Origin. Over to you, sir, for your discussion for today.
Preet, for the nice introduction. I'll be sharing my slide. Does my slide is visible?
Yes.
Yeah. I hope
Yes.
my slide
Yes,
is visible. Yeah.
Yes, it is.
Great. So what a nice presentation after Dr. Sana speaking for half an hour, like, keeping up to the pace of our conversation is definitely, I try to see, like, how best I can able to do justice for that. So since my topic has been literally put across keeping the WHO tools in the hospital and its effective implementation. So by and large, the principles what Dr. Sana and Preet echoed when you are developing a patient safety tool is definitely safe, effective, equitable, timely, and patient-centered is what, like, I don't want to repeat much on that, but at the same time, definitely when these tools have been developed, they have taken all those things into account and come across the multiple tools for safe implementation in the hospital setting. Strategically looking at why, how, what, all these question marks need to be put across, but at the same time, when you're framing your policies, developing any framework for across the globe, like, the thing is, there are healthcare of islands of excellence at the same time, like, some healthcare are at nascent stage. Yeah. So knowing that, like, the islands of excellence are there, but whatever I'll be muting everyone. Yeah. So the islands of excellence is on one side, but ultimately, like, when you are doing any of the programs, the leadership is the most important thing. And whatever the policies formulated by WHO is need to be percolated down to a smaller setup hospital or to, like, whether it can be used across the world to all different healthcare settings, different level, how it can be made standardized across, and how we can make it more people can use it, how it can be, there's an opportunity for an improvement. So as a part of a quality journey, we always talk about raising the bar, not compromising on the standards. So keeping all these fundamentals, values in mind, toolkits will be prepared, which are all literally developed based on the available evidences, and then it will be effectively implemented. Before we start anything and everything, we need to question ourselves, like, why are we doing it? So as a matter of fact, that all of us know, like, 1/10 of the patients do get admitted, do get the harm in one way or the other way, because of, as Dr. Sahana and Preet were explaining, like, multiple touch points, so much of communication gap, so many people they come across and interacting. In the process, a lot of errors can happen. But the cost of that error is something. I was reading this article. It is about something about some 7,000 million US dollars is the cost of that errors, is what in this tool they're notified. So ultimately, like, yes, how are we developing these frameworks, and how are we implementing these frameworks, and how are we going to make it effectively running? It's all about, like, in any organization, first thing is they need to have a very strong leadership. Leadership will get information from across world, what's happening, getting that on one side. And also, like, I'll take further details on the leadership subsequently, but you need to have, yes, you may be having good leadership, but thing is to implement what you want to think, you need to have a good team. So the team should be supported by fundamental structures of data collections, and develop an action plan to get the desired results in all sorts of walks. Like, what we do, like, we need to strengthen the system of reporting. It can be incident reporting, it can be system generated reporting, it can be, like, once the incidents have been reported, those incidents need to be analyzed. Definitely, wherever if need arises required, definitely people need to do a root cause analysis. And with all these things, as a part of the fact, you will come across with some correct actionables, and those actionables need to be rolled it out for implementation. In that journey, like, definitely you will involve the frontline staff, will be participating in both, giving you the inputs, assimilation of inputs, providing the processes, and then implementing it. End of the day, we need to empower the frontline staff for raising the important incidents, expressing their concerns, and, like, people should be vocal about if suppose something is not safe. So if that just culture was Dr. Sana was talking about, if that culture has been brought in, where people will reporting structure will be further strengthened, ultimately we get enough data to develop good, implementable, cost-effective, safe systems and tools, which can give you wonderful results, and we can make our places and premises as safe destination. Since, like, as I thought, let me take some time on dwelling upon WHO's effective leadership slides. Basically, leadership in patient safety is one thing. Is we need to be very clearly articulating and telling people about what's the goals and the objective we want to drive. See, is it real? And one more thing is, we always say is, like, zero error. So yes, zero error is the reason, because it's all about, we are dealing with human beings, we are dealing with patients, we are not dealing with machines, to say, like. So our goals and objectives need to be very clear, and we need to be open for taking the feedbacks and criticism from everyone. Ultimately, at the end of the day, it is to build a safe culture in the organization. As an individual, need to provide an effective leadership through effective communications. So there has to be a team with good camaraderie, relationship, inclusive in nature, and people should feel that we are part of the journey. So that's what, like, we are all going through. Like, in the last 20 years of working in Apollo, we started our initial accreditation in 2005, and today, like, we are hosting the 9th Patient Safety Conference. All of us are daily doing this. So whatever the experience, what we gather, like it all need to be shared, and we all should become comfortable and confident in decision making, maintain forward thinking. So thing is, if you are not open to look at what is the current, we need to shake the system. Basically by challenging each other, showing the data, what is the other world is doing, how they are able to produce such a good results. So with that, as it's a quality is a continuous journey of improvement, it needs to continuous review, critics and improvement on the line. At the same time, we need to create working strategies which can get the maximum effectiveness and the results. So any program what we are doing, we're going to run, it needs to be anchored or steward the program with available resources. Ultimately, constantly, we all need to strive for improvement of the process. Bug will definitely stop at us, and we are the one who going to set the agenda for our safety culture in the organization. So end of the day, we need the results. So these are the 5 tools, the tools which has come across, and one is on surgical safety, which is very effectively utilized across most of the accredited healthcare organizations. On medication safety, fall prevention, patient identification, hospital associated infections. So on all these 5 topics, I just quickly touch upon this. I'm not going into much details, but at the same time, these are very important points. Particularly, safe surgical checklist, as it's been developed by Atul Gawande, keeping the airline industry as a benchmark and developed, and it has been adopted. He being the surgeon. So the whole ecosystem, today, people are following it. Initially, there was a bit of resistance by the people in adopting the safe surgical checklist. So I just quickly take this upon on how are we making our organization safe. I always look at it keep giving a comparison of ourselves of because we are following with checks and balances in place. Currently, all of us are enjoying taking the pride. No such surgeries of wrong surgeries are happening. But how it's possible. It is possible because constantly everyone, you are putting the strong systems with some checks and balances. I'll tell you, without doing surgical site marking and without consenting, patient can't be shifted to the theater. So that is the checks. Even similarly, if there is no site marking and no consent is in place, patient can't be received in the OR. So that's kind of stringent systems what one need to put across. But at the same time, we always encourage patients to participate in surgical site marking. So patients get involved and participated, yes, I'm undergoing right TKR, this is the leg I have got pain, and this is the leg I'm undergoing surgery. And I'm the one who was given the consent. So then only patient will be taken into the theater. Very unlikely to wrong site, wrong surgeries can happen, provided if we follow such kind of things. Any events happening while surgery need to be captured. It can be an instrument, it can be any unanticipated events in the war. All those things need to be captured, should be analyzed, and people should come with corrective actions. As a part of the protocol of preventing hospital-associated infections and surgical site infections, the antibiotic administration within the 60 minutes before skin incision is becoming a standard habit. Yes, the anesthetist takes the pride when they're taking the patient inside the OR, they'll administer the antibiotic. So the patient is participated already on the floor for the consent taking and surgical site marking. When they enter into the OR, the verbal process of signing, the timeout and the sign out of looking at what all the instruments are intact, the needles count, the sponge count, the catheter tips, the tips of all the equipments are intact, checking all those things, labeling the specimen and sending it for the labs appropriately and closing the cavity is all part of WHO safe surgical checklist. People are very promptly practicing it across. Some few things like also people started reporting any adverse anesthesia events. Events can be anything. It can be like simple thing as laryngoscope light blade was not functioning, or it is got off when you're doing the dentures are not being or loose, or while intubating a denture can come out. So or there's a plan change of anesthesia plan. And unplanned return to the theaters. So this is another thing like need to be captured. See, ultimately, like the doctors, the nurses, the anesthetists, the technicians, and including the patients, all of them need to be empowered in bringing up the events, what's happening in the OR, sit across as a team in a multidisciplinary team, discuss and come with further corrective actionables to prevent such kind of any events or near misses. So medication safety is another dimensions which all of us know that medications safety is always a concern in the hospital. Reason because of multiple reasons. We will be knowing that, yes, of course, putting across high alert drugs, labeling the drugs, the prescription audit teams, what been put across, storage of medications, mainly like concentrated electrolytes are not been kept in the patient care units, and it's even if it is needed, like it will be dispensed by the clinical pharmacist in a diluted format. The diluted format of electrolytes, along with coming and checking by the clinical pharmacist for the rate of infusion. So those things have reduced the arithmetic adverse events which were leading as a cause of death in the past, and now labeling the lookalike sound-alike drugs in a different way with Alman letters, that's also takes care of that. Because of multiple specialists getting involved, a lot of medications patients do take. The medication reconciliation at every stage, from admission to discharge to daily medication orders. So noticing that therapeutic duplications, drug-drug interactions, and everything in mind, medicines need to be reconciled on every prescription. Plus also like, ultimately there has to be another check by prescription audit team to check all the prescriptions. And once the medications have been given, people should monitor for the effect of medications. Yes, a lot of standard set of orders practices is coming across, but the disadvantage is sometimes it is not tailor-made to the patients. So that customization, that's the reason, as I said, like medication reconciliation is required at every stage. You can't treat a patient uniformly across. Every patient is individual, is personalized medicines need to be taken care of. Yes, it can be prescribed. We need to capture every errors. It's not just only the administration error. It can, every near miss touch points need to be captured. And also like, procurement. During the COVID time, we have come across situations of stockouts. Some medications were not happening, not available. Those are all the part of pandemic situations. But at the same time, lessons learned. So getting the medicines, keeping the medicines available, looking at your reliable vendors, all those things are also additional learnings in that. Yes, as Dr. Sana said, like, we need to make the hospitals as safe place. Yes, safe places, environmental safety is one part, but we come across a lot of geriatric patients, vulnerable patients. Patients are taking on multiple medications. The environments are unfamiliar. The lighting conditions might not be appropriate. Patients do fall in the hospital setting. So it can really results in severe adverse events. So we have instances, we have stories where patients fell down from the cot and sustained on blood thinner, sustained a bleed, and eventually, patients might have succumbed. So those kind of stories also we keep hearing. So ultimately, every patient who comes into the hospital need to be assessed for fall risk at every stage. Even it can be an outpatient stage, it can be an inpatient admissions, or at the physiotherapy. So everyone need to look at who is vulnerable, how we can make them safer in the healthcare organization, what kind of supports and devices need to be provided to them to reduce the risk of fall. So these things need to be done. We do use comprehensive Apollo patient fall risk assessment tool to assess the patient fall, keeping the medication in mind, patient general condition in mind, age, vulnerable factors in mind. At the same time, if an event has happened, staff need to be trained on what to do to assess the post-fall assessment. In that post-fall assessment, we use two kind of things. One is on patient sustaining injuries and how are we going to handle it. Another thing is how this fall has happened. Is it due to because of medications? Is it because of system issues? Is it because of environmental issues? What is that, and come across with a corrective action for that. Yes, identification of patient is fundamental because as a part of international patient safety goals, the first goal is this. Reason is multiple touch points. It can be assessment of patient, to sample collection, to doing procedure, to analyzing the results, to releasing the result, to typing the discharge summary, or while reporting or transcribing the reports of the medications of the patients. At every stage, patient need to be identified properly. So we should never use the bed numbers, and there has to be at least 2 identifications. And what we have learned is, in particularly in our Indian context and the name reputations and all, we need to use full name and the UHID number of any particular organization what they come across. That need to be used. See, while when we are bringing this culture of importance of identifying patients, lot of stories each one of us come across. Those stories can be shared. So while sharing the stories, I always come across one thing which we always I always do share with the team is. There's a patient who comes for a health checkup, literally come and challenge us in our hospital that this is not my blood group. Then we said, sir, first point is let us revalidate your results before we conclude that. Then he said, yes, fine, please recheck it. So we did a test at our hospital as well as also at our neighbor hospital. What report we are given is the right, and the neighbor hospital what they given is also the same. So patient agreed and believed in. Then we went back and we sat such kind of things can happen once again. Our people can question us. So with our blood bank officer, we sat and we looked at. Then we come across, why can't we make the patient to participate while collecting the blood sample? So in 2008, we come across this system of making patient to acknowledge on the patient label, identifying the patient name and UHID number, and witnessing for sticking the sample. In one go, that pre-analytical error has been taken off. Today, I would say most of the enable accredited hospitals, they're all following this as a standard process. We are quite happy that what we have thought and we have implemented, it has been effectively, it's been used across the country by most of the enable accredited labs. So then this is hospital associated infections, preventing it is the universal thing which all of us do. As a part of the story, we always says, infection control is everyone's business. It's not only to the clinician or to the management or to the facility head. It is everyone need to participate in that. It comes from hand hygiene to environmental hygiene, what kind of environmental controls we have, as Dr. Sana has mentioned. At the same time, screening of cohorts of patients and isolating them to the areas, particularly if the patient is a neutropenic patient or a pulmonary tuberculosis or the COVID one, how are we isolating the respiratory illness patients? And also, like, continuous constant surveillance about the systems, how effectively systems are, plus follow the guidelines, whether it can be a hand hygiene, WHO or 2009 guidelines on steps of hand wash on that adherence, or the antibiotic stewardship program, or for that matter, bundle compliances. See, in all these things, there are periodic guidelines coming across. It can be coming from CDC or it can be coming from your own association, professional bodies. But people need to keep abreast with the technology system and all. People need to be very watchful about the whole thing. So we also need to have an antibiogram, and with the antibiogram, tracking the looking at, like, this trend of usage of antibiotics is another thing, and also, like, containing the spread of if any outbreaks happens, how effectively we going to handle and contain the spread is equally important. Most importantly, making staff and the including our housekeeping staff as champions of the process of infection control. Today, something like, the hand hygiene compliances are on the higher level because of the awareness level what we have created due to pandemic. We may be having sitting with a good control of infections in the hospital. Most importantly, like, whatever we do, like, if the culture in the organization need to be addressed, keeping all these things in mind. So I just thought of taking it what is there in the WHO thing. Basically, like, ownership in engagement with the staff, leadership and a blame-free environment, what Dr. Sana said, and the openness across the organization, encouraging staff to speak up. Suppose something is wrong, like, they need to bring it up. Plus, all of us need to work as a team in a collaborative way. Report events, incidents, and all. So we also need to know, like, where do we stand with respect to culture of safety in the organization. Across Apollo, like, we do measure the culture of safety scores in a year, and as an open organization, we always tend to push people to know that, like, there's a series of trend of improvement story what we see across most of the hospitals. In that, like, because of participative mechanism, open forums, people can express their concern, encouraging people to raise incident reports, constant quality systems, reviewing of about our systems, internal regular audits. So these things have literally helped us in improving our trends. At the same time, like, anything which is coming across as actionables, we'll work on that. Most of the things, like, what we are coming across is the second victim. What is that called? Second victim. Yeah. So typically, like, second victim is the one, like, I raise the some incident has happened, event has happened in the organization, but how are we going to safeguard the interest of the one who was got affected or was involved in that? So even we started talking to them, telling them, expressing that it is not putting you down. It is all about, like, just we want to know what's happened, how it's happened, what were you doing, where were you, whether you had a good sleep, are you under stress, like, how it has happened. So this is just we want to know, so that in future that need to be avoided. We are all there. There's a buddy system is there to support the colleagues, and there's also a reassurance coming from the leadership that there is no punitive action in the hospital. You tell us, like, give us an example, anyone we have fired because of such kind of events happen in the hospital. with that, we are all overcoming. It's a promising effort, but still it's a constant journey, as because of 30% of our staff will be getting changed in the year. It is a continuous journey. We keep nurturing in the organization, and ultimately what we all want is empowered patient, empowered employees, and we all need to come together to build a safer healthcare system. I think WHO is doing a great job in looking at diversities and keeping the islands of excellence in mind to what is needed. I think it's a long journey. We need to constantly look at things and systems, recheck our systems, empower our people, and provide a safe environment. So with that, I'll be able to close any questions. I'm ready to take that.
Thank you, Dr. Jatish, for such an insightful discussion on using the WHO tool for structuring the patient safety plan. We could gather some key takeaways, which are that leadership qualities are very much essential for developing patient safety. We need to use the toolkits given by the WHO while developing a patient safety framework in our respective hospitals, and how important it is to build the culture of safety in a healthcare organization. Now, we shall be taking up questions from the audience. So we have the first question here. So this is from Dr. Bharat, and he's asking how to handle a personnel who has been responsible to have made an error which led to an adverse event. Have you experienced any situation like this? How did you successfully handle this? So I'm requesting Dr. Jatish to please answer this question.
Yeah, it's a day-to-day challenge. As I said, the minute an event has happened, particularly we are listening to a lot of stories coming across. It can be what's happened in Jaipur or Rajasthan, or what's happened. I'm talking about the broader thing. So we need to there has to be a two types of thing approach. One is meet the person, reassure them, yes, please tell me and help us out how it's happened, what we can do to prevent it in recurrence. See, if it is a day-to-day small mistakes or anything, we need to make them, yes, how can you prevent it in the future? What is the shortcut you have taken? So what can we do? So then they will come across with themselves this is what has happened. We should have followed this. I should have not taken the shortcut like this. Then I said, why don't you use this your learning to other staff? Why can't so that everyone knows that yes, I did that, and we come across with this system we have put in, so that this event is not going to repeat. Yes, particularly I may be talking about generic, but specifics to that is as a part of initial reaction, staff take it they may go down, or they may be reactive, they may be isolating themselves, but it is the duty of us to give them that common side confidence, reassurance. We are there with you, but it can happen to anyone at any point of time. But at the same time, what we can do to overcome it and preventing it from recurrence. Yes, definitely, we are rustling with that on a regular basis. It is telling is something to what is we are practicing. It is not different. Walk the talk is most important. Be with your employee and give them the sense of confidence. There will be a lot of positive reinforcement happening. The peer will come together. They will help each other, handhold, and ultimately we need to address that if it all depends on what level of events it is. If it is a minor event, we look at what we can build a better system. If it is a real adverse event where the outcomes are getting affected, in that case, definitely we do a detailed RCA where we'll make everyone part of the process, including the person who's getting involved the people get involved. That's how, like, we are overcoming. Yeah.
Dr. Sahana, we have another question from Dr. Libin. So he would like to know that, about the patient labeling on the blood sample procedure. So doesn't illegibility come into play if we ask the patient to write their own labels along with other problems? How does that play out in reducing IPSG-1 errors in the patient sample? So he's asking for a patient's role in labeling, Dr. Sahana.
Yeah, so Livin, that is a valid point that you make, but the idea is bigger than that. The idea is IPSG-1 essentially says you identify a patient correctly using two patient identifiers. So obviously every hospital is going to have the name of the patient as one identifier, and you're going to have some record number, some medical record number, depending on what your organization has chosen to use as the other patient identifiers. So the idea here is more of empowering that person, the patient, and saying that, we printed out patient labels. It has got your name, it's got the date, it's got the medical record number. And in front of us, for the labels, you put your signature. It could be a short signature. It could just be, just an acknowledgement that this is me. And so the patient actually reads the name, reads the record number, and agrees that it is correct, and has agreed that that person is himself or herself, and acknowledges that with a short signature. So the eligibility basically of that patient and all that doesn't really come into the play per se, because we are asking the patient to identify himself or herself correctly. And that is how the IPSG-1 is coming there, to reduce the errors. And we make sure that each vacutainer or each container is actually labeled in front of the patient, and the samples are drawn into the same containers that has been labeled. And that is the role of having the patient label signed by the patient and by the patient themselves. That is the role of it.
Thank you, Dr. Sahana. This is, this is the time that we have for audience questions. If we have more questions coming in, we will address them separately and we'll write back to the audience. And so before we close today's session, I have a few important announcements to make. Our next webinar is scheduled for 6th of February, Monday, and the topic is nursing and patient safety. So do register yourself on the same link and attend this important session. The session will be live streamed on our YouTube channel as well. Also, next slide, please, Soma. Please attend in person at Delhi our pre-conference workshops scheduled for the 11th of February. The topics are facility management and safety, clinical audits and pathways, medication safety, risk management, and service excellence. For the International Patient Safety Conference scheduled on 13th and 14th February at Taj Palace, New Delhi, we have very limited seats left now. So please register and reserve your place at the earliest. For more information, do visit our website or feel free to call us. At the end, on behalf of Apollo Hospitals, I would like to thank again our audience for their active participation in today's session. And last of all, but not the least, a very big thank you to our honored speakers, Dr. Sahana, Dr. Jatish, for their time. And my colleagues, Rekha and Soma, for being there and helping us out through this webinar. Thank you so much.
Thank you, Preet, Soma, Rekha, and you guys have done a wonderful job. Thank you, Dr. Sahana. It's good talk.
Thank you so much. A pleasure. Thank you.
Thank you.
Thank you, everyone.